Next panel. We want to make sure that there's time for everyone to interact with our panelists. And this panel is going to be moderated by Dr. Karen B. Francis, who is a senior researcher at the American Institute for Research. She's currently a training and technical assistance specialist on disproportionate minority contact for the State Training and Technical Assistance Center, and works in a variety of research, training, and technical assistance capacities. She has and is currently involved in providing technical assistance for juvenile justice, schools, and community-based organizations to examine the impact of implicit bias on decision-making. She also works as a lead consultant for school districts, and we're very pleased to have her with us this morning to moderate our second panel.
Thank you very much. Good morning. So before we begin, I have been asked, apparently someone has lost their claim ticket for their vehicle. So if you plan on going home this evening, the number is 03730. So this claim ticket will be here, and I'll make sure that it is up at the registration desk for you. So again, don't forget, if you plan on going home this evening, you don't want to take a cab home. All right. Well, good morning again. It's really my pleasure to be here, and I will serve as the moderator for this panel this morning. We also have the pleasure of three distinguished panelists this morning. Dr. Katherine Marshall-Woods, who is president and co-owner of Psychological Group of Washington. Dr. Gloria Wilder, who is president and CEO of Core Health and Wellness Centers, and Miss Kai Queen Wilder, and I just love saying that, student and youth mental and behavioral health advocate and ambassador. So welcome, thank you. Our session this morning, lock up or lockdown. Wow. What a sad commentary that makes about the options available for healthcare. Lock up or lockdown are not the only options that I would have liked for my cousins who have had mental health concerns. Sadly, those are the options and circumstances that they found themselves in, one in jail and the other institutionalized. A reality that leaves my family devastated and wondering, what went wrong? How did this happen? Why this family? Why did this happen to us? What should have been done? What did we miss? What did we want to not see? Could we have done something different? Did we even know where to go? Did we want to let the world know what was going on or what we may have suspected? We thought that we could handle this. Where were the services? How could we access them? Those are all the questions that we asked. So in setting the stage this morning for this session, I just want us to consider some research that tells us about the perpetuation of disparities in mental health and mental health care in this country. Firstly, Blacks and Latinos are more likely than whites to be uninsured, and the lack of insurance is a strong negative predictor of utilization of mental health care. At the provider level, physicians were found to be less likely to identify mental illness among racial and ethnic minority patients compared to white patients, possibly because of the inadequacies of standardized screening and diagnostics instruments to detect mental illness in minority populations, or greater levels of miscommunication between patient and providers because of different language, culture, or communication patterns. Blacks and Latinos are more likely than whites to perceive stigma and financial barriers to mental health care, disproportionately endorsing embarrassment to discuss problems, loss of pay from work, and concerns of losing employment as barriers to receiving mental health treatment. White, Black, and white Latino disparities in the use of any mental health care increased between 1990 and 2003, particularly between whites and Blacks who use care in general medical sectors and between whites and Latinos who use care in the specialty mental health sector. Disparities persisted between whites and blacks in the use of minimally adequate mental health care. In the mental health sector, we're focusing on the issue of the lack of psychiatrists and psychologists from racial and ethnic minority groups in this sector. In 2005, only 3% of psychiatrists and 2% of psychologists were black, and 5% of psychiatrists and 3% of psychologists were Latino. Researchers also posit that racial and ethnic disparities in mental health research posits that racial and ethnic disparities in the mental health workforce may account for disparities in care because of the greater need for cultural sensitivity in dealing with mental health issues, extensive issues of trust, and increasing language barriers between providers and patients. So at the heart, really, of this conversation are the following factors that contribute to mental health disparities: unfair treatment and financial limitations, stigma related to mental health, and the existence of a fragmented mental health system. So, what do we do to understand the nature of the mental health disparities based on factors such as access, the affordability, acceptability, availability, or even accountability? I now turn to our panelists to help us answer these questions. So, Dr. Wilder. She said, Dr. Marshall Woods.
Thank you. Good morning. It's nice to be here with you this morning. Today, what I'd really like to discuss is assessing mental health care within our communities and the challenges that we face in doing so. The 4 points that I'd like us to consider today are financial limitations, access and availability of mental health providers, the educational services that are provided, and the systems that are in place to help our children, as well as attitudes towards mental health. Nationally, 42 million adults aged 18 and or older experienced a mental health illness within the past year, and that's about 18.2% of our population. However, only less than 4 in 10 adults with mental health issues actually received mental health treatment, which is a significant discrepancy. Services used was higher for individuals with serious mental health illnesses. However, 4.4 million individuals with serious mental health issues did not receive mental health treatment. In 2012, 62% of adults with serious mental illnesses received mental health treatment within that year. And in DC in particular, 35,000 individuals received treatment. And I place this up to indicate that things have gotten better actually over the years, that this is actually an increase of individuals assessing mental health. However, of course, we still have many burdens in order to overcome, and one is financial. Budget cuts have made up a significant difficulty in getting mental health care. Specifically during the recession, budget cuts were made $1.8 billion for mental health budgets, and in DC in particular, 19% of the budget was cut. 45% of untreated diagnosed individuals that had mental health issues stated that the reason why they didn't get mental health care was because of financial reasons. And partly it's because many individuals still rely upon paying out of pocket for mental health care. Out-of-pocket care is very expensive for most individuals, where most services range from $100 to $5,000. And most people ask me, what service do you get from a psychologist that is $5,000 for one service? And usually that includes psychological testing as well as neuropsychological testing. 70% of children in need of mental health services do not receive care, partly citing that cost is a barrier. Thus, a quarter of 15.7 million adults who receive mental health care listed themselves as primarily remaining the main payer for their services. I wanted to highlight this slide because there is a idea that therapy takes a long time in order to receive benefits, and thus individuals feel that they must invest years of their life in order to heal psychologically. And albeit that might be true, however, the mean treatment care is actually anywhere between 7 to 20 sessions in order to begin to feel some level of benefit through psychotherapy. And these are the different modalities that are most commonly used. And so most times, if an individual invests 7 to 20 sessions, they actually begin to feel much better regarding their circumstances and be able to adopt coping strategies to assist them in future endeavors. Switching subjects is access and availability, and I know that it was mentioned by my colleague here how psychologists are very slim, which data shows that. Is that actually accessing mental health professionals is worse than any other type of physician and or doctor. Specifically, 89.3 Americans live in an area where they have a shortage of psychological treatment, whereas, let's say, compared to 55.3 Americans who live in an area that has a shortage of a physician and or 44.6 million individuals who have a shortage of dentists. Thus, many or more than 20% of the children who have mental health problems may not receive care. And they actually look to schools in order to assist them in receiving that care. However, 13% of the 6.5 million public schools, the students are enrolled in special education. And this is a very important fact. Going here is that many children do not necessarily access mental health services when needed within the educational system, and we'll talk about that a little bit later. What happens is that if an individual does have mental health issues and do not access it within the school setting, if you're a child, here are some of the options. Parents have a right to get services through the community if they can afford that. There are students who matriculate through inpatient residential facilities. They may access 504 section plans within the Individuals with Disabilities Act law and or receive no treatment at all. And this does not take into consideration students who are not eligible for special education and or 504 plans, which means they may not have a disability, however, still have difficulties coping and maintaining functioning within the academic environment and or their overall life. Within schools, which is also a challenge, is that school psychologists are also short in supply. According to NAS, which is the National Association of School Psychologists, they recommend that for every 500 to 700 children, one psychologist is available to treat those children. However, in most states, we're looking at that one psychologist is responsible for 2,000 to 3,500 students. And if you can imagine providing hourly sessions for students, that looks a little overwhelming for one psychologist. So we have some educational services and systems that are in place to assist. There are two ways that children can access mental health services on a regular basis within the school setting, and that is through the Individuals with Disabilities Education Act, which actually was improved in 2004, as well as within the Section 504 of the Rehabilitation Act of 1973. The law says is that if a child qualifies for special education, they fall under IDEIA. However, there are some criteria that they have to meet. One includes that they have to have one of the 13 disabilities listed as one that will qualify you for services. And the second is that it has to impact your ability to access the general education setting. So an individual may have a disability. They may, let's say, have bipolar disorder. However, if it is not negatively impacting their ability to function within the classroom setting, they may not receive care at all. And here are the list of the 13 disabilities available through IDEIA, which is special education law. There is one that is not added and is highlighted at the bottom, which some states recognize, which is developmental disabilities, and that goes between the ages of 7 until 9 years old until a formal diagnosis can be provided. On the other hand, if a student has a disability, however, does not meet qualification for special education, they can potentially receive care through 504 plans. And these 504 plans state that students are eligible if they have a diagnosis and continue to have challenges within the academic environment. However, there are still students that fall through the cracks. Unfortunately, many times when individuals are searching for treatment, we find that these issues are systemic. So most parents come in for therapy services, the family comes in for therapy services, which of course can be costly, and then they would want their child to also be seen and or assessed. So this becomes a very large financial weekly budget for the family. Relying upon the public education assist in that process and being able to access those services on a weekly basis for their children. One thing that I did want to highlight is that when students qualify for 504 plans, there is no federal funding that's given to the school at this time to service these children. So for individuals under 504, that is coming from the school's budgets to service other parts of their school. So this generally means that there's a very small amount of money to service these students within the public education setting. Lastly, I just wanted to highlight attitudes towards mental health, and I'm sure we'll be talking a lot about that, so I'm just going to be very brief, is that most individuals assessing mental health still feel that there is a major stigma regarding receiving help and identifying themselves to have a disability and/or a diagnosis. Individuals usually are very hesitant to access mental health, even if they're aware that they may benefit from receiving the service. In part, 66% of new patients state that they felt that the problem would just get better on its own, and 71% wanted to figure out ways in order to solve the problems on their own. A lack of understanding and education regarding mental health services, diagnoses, symptoms, presentation, and prognoses, therapy, assessments, fosters this environment of feeling like that you cannot get services and/or you feel that there is a challenge in getting it and what that will mean for yourself as a personality and who you are. And this is actually something that is very dear to my heart in making that mental health is accessible for most individuals with receiving education. Based upon this of lack of education and understanding regarding what the diagnoses are and what symptoms you'd like to see in those diagnoses causes individuals to have a very difficult time putting forth the effort to say, I need help. Thank you.
Thank you, Dr. Woods, and I'd like to invite Dr. Wilder.
Good morning, everybody. And thanks for coming out in the rain. It is really pouring out there. In talking about the issues that we face with mental health services, I'm going to talk from the perspective of a pediatrician and a mother, which I am both. I've been a pediatrician for about 23 years now, and I've been a mother for 27 years. And those two worlds collided for me, came hand in hand within my own family in thinking about these issues. And I really love the title of this session today, Lock Up or Lock Down, because I think for a lot of families who are faced with challenges in the mental health system, it really does become that black and white sometimes in order to get your family member care. You're often pitted against your own family member. So, I would like to just start by telling you guys about a young lady named Carrie. And Carrie Anderson in 1944 is this beautiful African-American young lady. She is caramel chocolate brown, and she is married to a man, and they have 3 children. And their 4th child arrives, and Carrie becomes this, elegant mother who takes very good care of her children and is a doting wife and a stay-at-home mom. And Carrie one day decides to take her youngest child, Teresa, and she puts the baby in a carriage, and she's dressed just so perfectly in a beautiful dress and heels, and she's taking her daughter for a walk. in the Brooklyn neighborhood where they live. And Carrie walks down the street with the stroller in front of her, and suddenly Carrie just walks to the corner of the street and sees a truck coming down from the other street. And she waits for the truck to get close, and she walks into the street, pushing the stroller in front of her as the truck barrels down. And Carrie waits for the truck to reach her, and she falls, and the stroller falls forward, and Carrie is struck by the truck. The stroller makes it to the other end of the street where it falls over, and the beautiful baby girl named Teresa falls out, and people now have arrived, and they're picking up this girl and calling for help for the elegantly dressed mother who has been struck by the truck. Carrie Anderson would spend the next 70 years of her life in a nursing home in New York City. Her daughter, little Teresa, would grow up to be my mother and would give birth to 3 children of her own. One of her children, her eldest child, a daughter, would at 21 years old have her first schizophrenic break and move her 2 sons to California from New York City in one night, thinking that she had been called to be with Michael Jackson. And Teresa, whose mother sits in a nursing home, never connects the dots between her mother and her daughter. And I, the middle child of Teresa, would grow up to have 4 children of my own. And as a family, we would support our sister in trying to get her mental health services in now California. The result of which meant that as a medical student, because at the time I was at Georgetown in medical school, I would fly to California 6 times to get my nephews, her children, out of foster care. They were put in foster care because their mother was seen being unstable with them in the street. And rather than contacting any family members, the thought was to put these 2 young men in foster care and put her in a mental institution. And the boys relay that they would say numbers of times who their family is in Brooklyn. And these boys were 12 and 7 years old. They knew their grandparents' numbers and their aunt's number. But it took us 6 trips to California to get the boys back. And after that, we would later get my sister to return to Virginia to live with me. In our family, mental health services have never been something that we thought a lot about. We didn't prepare for it. Who knew, right? So when it happened, just like a lot of families, it becomes a crisis, but it's a crisis because there's no preparation. There's no education. There's no entree into what do you do if somebody in your family is having a struggle. We were prepared for heart attacks, strokes, heart disease, right? We knew cholesterol levels, right? Because our community has been educated about that. We know how to prevent sexually transmitted diseases. But what do you do when there's a different kind of struggle? So we would return my sister home, and in about 5 years after that, her eldest son was diagnosed with schizophrenia, like his mother. And now we were a little bit more prepared. And for me as a pediatrician, at the same time that this is going on for me personally, you know, I'm seeing children here in the District of Columbia who have absolutely no services available to them, or very few services at that time. We're out on mobile medical units next to the Capitol trying to provide health care services to kids who are living on the street or who are living in public housing but just don't have access. The Affordable Care Act is going to help with some of that, right? It creates a payment mechanism, right? But I think almost everybody in this room recognizes that there's a larger issue, right? And it's about access to quality. Just having the ability to pay for a service doesn't mean you have access to the service. And in some parts of our nation, including most major inner cities, access to quality mental health services is like access to a diamond, right? Oh, it's there, but somebody else is wearing it. And so we have work to do when it comes to talking about how do we end what is truly economic segregation in healthcare services. That's what it is. Because if you've got the money, and we've heard some of the prices, right? It's not that people aren't working hard, but the truth is, you got to have a lot of money to access these services. Otherwise, you're likely to get services that some of us might consider substandard or just not enough, right? Maybe they give you 4 sessions instead of 7. Maybe you find out that your co-payment is so high that you don't take any sessions. And so we struggle in our country to be honest about why we have the haves and have-nots of access. I personally promote and hope we will all push towards mainstreaming mental health services as a primary care service. Just like you get to have an annual visit with me or the internist or the family practice physician, if you need a mental health provider, it should be considered a primary care service. Why are we carving this out? It's absolutely ridiculous. And I think it's biased. It speaks to our base fear of a population of residents in our communities. So for me, 63 years after Carrie Anderson pushed that stroller across the street, I sent my 14-year-old daughter, who's the light of my life, because see, I've got 3 sons. Okay, I know all the mothers now are understanding. I have 3 sons and I have 1 daughter. And when I say I waited for this child, I was so happy when the OB said, it's a girl, you know, I was just like, oh my God, finally somebody who will understand me. And she grew up to be this just ball of energy and beauty and light in our family. My daughter, from the moment she came out the womb, she would climb on like the back of the sofa. She'd climb to the top. She'd spread her arms wide, and she'd just jump. Like at 1 year old, ah, like that. And me and her father would look like, oh my God. She had no fear, and she still has no fear. And 63 years later, after Carrie pushed that stroller across the street, I sent my daughter to New York, where my family lives. We still have our home in Brooklyn, the home that Carrie Anderson raised her children in. And she was to attend the Dance Center of Broadway and Dance Theater of Harlem because she's this beautiful dancer. And that summer, she was there for a couple of weeks, and I get a phone call, and my aunt is on the phone, and she says, Kai is missing. I said, what do you mean Kai is missing? Well, we don't know. We saw her get into a car, and we can't find her. Nobody can find her. My daughter would be missing in New York for 5 days. It took us 72 hours to beg to get her on the National Exploited and Missing Child's website, because, you know, it's hard to get black children on that, all right? Especially if they're over 13, because everybody considers them a runaway, even when most of the time they're not. And we would look everywhere, and 5 days later, my daughter was located and brought to Mount Sinai Hospital, where I was with her in the ER, in the psych section of the ER. And I'm sitting next to my daughter in a locked psych ward with adults all around us who are mentally ill. And there's a big bulletproof glass, and on the other side of it are the doctors and the nurses, and we're on this side. And suddenly my daughter looks at me and she says, Mommy, I love you. And she falls over saying, Mommy, I'm sorry. I'm sorry. And she hits the floor. And now, 63 years later, after Carrie Anderson pushed the stroller, I am resuscitating my daughter. And those doctors and nurses are watching me. And I am looking up and I'm saying, help me. My daughter would spend the next 3 months in and out of Mount Sinai until we could get her back here to Virginia. And at a cost of $15,000 a month, we got her into a long-term residential treatment facility only because we qualified for emergency Medicaid. As a doctor, I qualified for emergency Medicaid. Most people wouldn't even know to apply. And my husband, my ex-husband at the time, was a police officer, Fairfax County, and we qualified. And in Virginia, there's something called the Community Services Board that paid the difference between what Medicaid would pay for this long-term facility, where my daughter spent 6 months able to go to school, able to take the time to start to heal, and for us to recover our relationship, and for me to find out that there was a lot I didn't know about what I contributed to with my daughter. When we talk about lock up or lock down, for families with mental illness in the family, honestly, we just want to be treated like any other family who has any kind of illness. Treat us like asthmatics. Treat us like folks who have ingrown toenail. Allow us to publicly talk about our lives and our stories. And allow these beautiful children, like my daughter, to fly. I want to introduce you to Kai Queen Wilder, who is now 21 years old, and she runs the fitness services. She's the fitness coordinator at our wellness centers, certified yoga instructor, and she is my daughter and Carrie Anderson's great-great-granddaughter. Thank you. Go get him.
Good morning, everyone. I'm honored to be here today, and I thank you for the opportunity to speak on not only behalf of myself, but all those who have shared experiences like myself, not only in America, but around the world, with discrepancies in mental health. I, as a child, grew up with a mother who was deeply involved in the developments and practices of social justice in the United States of America. And I was exposed early and learned a lot about the different experiences that many of people share just along the journey of life. And in recognizing that there was so much suffering around the simple act of survival, I had an experience of depression from a very early age. A lot of that stemmed from traumatic experiences within the community, traumatic experiences that is very deeply ingrained in our history, traumatic experiences that are experienced on a personal level. And by the time I was 14 years old, I find myself, along with many of my peers, searching for something, a meaning, a purpose, and an opportunity to experience life on a basis beyond the vain or mundane, to align ourselves with the purpose that gave it all meaning. The struggles that our family share just to provide care, just to provide shelter, to provide food, the experiences that our companions and peers have to recognize on a daily basis just in traveling the streets, going to school, going to work, and recognizing, as my mother mentioned, that we're provided resources for a lot of things aside from kind of the most fundamental aspects of life. So, in my experience, since the age of 16, when I got diagnosed with bipolar disorder for a depressive state and also a manic state where you have a higher perspective of the life in front of you and perspective on the things you see, I recognized that with all the services that I had been exposed to in that time, none of those things were willing to acknowledge the traumas I had faced, the experiences that I had partaken in life, that life had shared with me. And that by far contributed further to more trauma. The inability and the not having the opportunity to express the experiences we share or the experiences we have contribute greatly to the conflict within an individual. And I'm here to attest for the fact that health and recovery are hugely parallel to a state of equality of being, a quality of mind, and a state of peace within the self. When there are so many aspects of life that are negatively influencing or possibly negatively impacting the state of being within any individual, it creates huge amounts of conflict and huge difficulties in that individual to maintain a consistent state of mind or state of being, especially when there's a reluctance in the community or even as a youth, for the adults, the providers, the teachers, when there's a reluctance to address or acknowledge the experiences that the youth are having. So during my 3 months in Mount Sinai, I was given huge and heavy amounts of medication to alleviate depressive symptoms. Now, there's a huge medical side to the different chemical imbalances and what medications can do to assist in that. However, the core of the experiences that I was having had to do with the fact that my life had come to shambles as I knew it. My family was now dealing with an experience they had never had before, and there was no one there to assist my family with what they were experiencing, nor was there anyone there to assist me with the experiences that I was having and had had as a child. So in that time, I was now having to take huge amounts of medication and being locked up as far as the lockup or lockdown situation goes. I was locked up and being required to take medication until they saw that I was fit to return back to normal life, what they consider, and they returned me back to school, the normal school system, where, again, there are no resources to deal with the traumatic situations, events, or experiences that I had been exposed to. Now, during my 6 months at a residential treatment center, I had the opportunity to share an experience amongst about 20 to 25 other girls my age who all had also shared traumatic experiences, such as myself. And the experience exposed to us a commonality in the situations upon which we grew up. The fact that many of us had no one to turn to, no one to talk to, nor did we have any environment where the situations or experiences that we had been a part of or that had been exposed to us were acceptable as conversation or acceptable, period. As far as the conversation of stigma goes, we all genuinely believe that stigma has such a negative impact on our health and recovery, our healing, due to its identification beyond humanity. Once we are given these diagnoses of whatever it may be, we're no longer identified as the girls we once were, not to our friends, not to our family, and definitely not to the community that surrounds us. The healthcare system treats us solely on our diagnoses. When we're in the treatment centers, when we're being hospitalized, we are identified as our diagnoses, we're identified as our symptoms, and we're treated on our behavior that day. We're also being rated on our ability to manage however we feel, despite the circumstances, despite what may be occurring in real time, or despite what we may be dealing with our experiences of the past. After being released from my residential treatment, I then had to go on a 3-year journey. I was an advanced studies student in high school before this occurrence at 16 years old. And upon leaving my treatment center, I was able to graduate high school a year early due to the credits I had received in my freshman and sophomore years of high school. And after that, I went on to study at community college. I went to study psychology. And of course, naturally, in the pursuits to understand what the world was telling me was occurring with me compared to the experiences I had personally had in my life. And I recognized throughout the journey that by far, beyond anything they could relay to me scientifically, beyond anything they could prove to me by, any of these medical services that I had been exposed to, that every bit of pain, suffering, and trauma that I was experiencing as a child, as a youth, and now as a young adult had stemmed from the direct experiences I had had in life thus far. And I recognize that going forward, my only opportunity to heal, my only opportunity to proceed with a clean slate and a true purpose, and to re-attain the state of being I once had as a child, where all things were possible for myself, for my peers, where once upon a time we could do all the things that we knew we could do, that we believed we could do. It required me to address and acknowledge every single thing I had ever been through. To address and acknowledge every single thing that had happened to me, whether or not my providers, my family, or the community that surrounded me were willing to have the conversation with me. Going forward, my studies concluded to all aspects of the self. I am now a certified yoga and meditation instructor, and I intend to further my career by studying integrative medicine. I acknowledge 4 aspects of what I personally feel have all contributed intensely to my healing and my ability to be in a state of mind, a state of being, and an absolute presence that allows me to function and to succeed in my everyday life and all of my pursuits. The aspects of my personal care that contributed to my healing were 1, self-care, 2, self-acceptance, 3, self-development, and 4, which are 2 aspects, self-study and self-knowledge. All of these aspects allowed me to proceed into a place where I came to understand my place of mind, the occurrences within my body and of my body. My studies have revealed to me trauma is held not only in the mind but in the body as well. And that there are many practices and arts available that allow the individual not only acceptance and surrender to the experiences that were once upon them, but the ability and capability to accept, surrender, and release those experiences, to reattain a space of being that is just present in the now, and allows them to reattain a state of balance and stability within themselves. Aspects of the self are the mind, the body, and the spirit or will. The part of you that is a presence, that has an awareness, that is the part of you that partakes in every experience you are a part of, that listens, that witnesses. And that part of you is the part of you that has the ability to relieve you of anything that was a part of the past and anything that can potentially be a part of the future. A reconnection with that part of the self allows the individual to comprehend the experiences they had been a part of. Also, I'd like to say that a management of the mind is required to attain mental stability, no matter what the disability, disorder, or dis-ease is in the individual. All aspects of mental health care have to do with the occurrences and operations of the mind. So if the individual is not in a place to acknowledge the processes that are occurring within their own mind and mental space, and they're never afforded the opportunity or never directed in that direction to pay attention to what's occurring within the self, aside from all of the external variables and options that are in front of them, they will very rarely attain a state of being that is back to that balance and stability. I would just like that the future focus of mental health care in America returns to a place where you are empowering the individual to gain a state of presence, a state of stability, and a state of ease in being. Beyond the priority being the functioning in the world, the functioning in what is required and expected of us around us, whether that's in school, work, whatever the case may be. The priority must return to the individual, re-attaining their individuality, re-attaining and understanding and respect and love for themselves, beyond all and any difficulties they may face in the world or in life. I thank you again for allowing me to speak today, and may we all reattain a space within ourselves where we are accountable for, willing to acknowledge, and willing to trust ourselves to care and provide for ourselves. And may the focus return to healing. Thank you very much.
So I'd like to turn the mics over to anyone with questions or comments from this session before we do the wrap up. So any questions for any of our panelists? Okay, all right. So you already have your customer here. Mm-hmm. Yes.
I teach I teach in Washington, D.C. at Core Health and Wellness Centers in Washington, D.C., as well as in New York City. So we'll definitely pass out contact information as well. Thank you. I appreciate it.
I have a comment.
Yes.
Okay, Ms. Wilder, first of all, that was absolutely phenomenal, as you are. Dr. Woods, I'd like to address your presentation, which was excellent. You talked about the fact that there were 2 ways to access mental health services if you are a student. There is one more, and it's one of the best kept secrets. It's response to intervention, which is under No Child Left Behind, which falls under the Elementary and Secondary Education Act. The nice thing about response to intervention, if and when it's done, and schools are required to do it, is that the child is provided with an academic and behavioral intervention strategies plan. Now, that behavioral piece is important because usually kids don't get referred because they're failing math. They get referred because they're jumping on the desk after they failed math. And so one thing that's very important about that, though, under response to intervention, unlike IDEA and 504, is that when this plan is developed and the parent is part of the team, you can include issues that occur not just at school, but at home and the community. And you are absolutely forbidden to do that under IDEA or 504. And the other thing I wanted to talk about was in terms of behavioral health issues, mental health issues, Training is extremely important. Within the early childhood community, if you're talking about developmental issues to a teacher and you say, this child is having trouble with their language or speech, what do they need? Teachers respond. They need speech services. If you say this child is having trouble motorically, what do they need? They need a physical therapist or occupational therapy services. If you say that a child, particularly a male child, 3 years old, is having behavior issues, he's just a badass kid. That is not considered development. And so there has to be a lot of training. But going back to what Dr. James said, that until we begin to address issues collectively, like the physician is talking to the educator, who's talking to the psychologist, who's talking to the social worker, nothing's going to change. Because you have parents that will go to a physician and the child may have speech issues. And the doctor points that out. Yes, the child has speech issues, but there is never the answer or the question because that child has been receiving speech services in school, but they haven't done anything. So you have to begin to look at the child collectively and, as Ms. Wilder pointed out, not just look at a diagnosis. But until we begin to come together collectively as physicians, as professionals, and talk about all these issues, we're going to be in the same place. We're going to be talking about these same things 10 years from now.
Sure. Actually, RTI is a wonderful program, and I'm glad that you brought it up. And it is a very well-kept secret regarding the interventions that can be placed, functional behavioral assessments, behavioral intervention plans, as well as working with families within the community can be done by RTI. Exactly. And most of the schools actually do have student support teams or teacher assistant teams that function in that service. And albeit all schools should have RTI teams, unfortunately the reality is that they don't, and or they don't function efficiently. Many times RTI is the 6 weeks, individuals see it as a very brief setting where you take a student and guide them through an RTI session for about 6 weeks in order to monitor their behaviors and or functioning, and then determine whether or not they qualify for special education and or 504s, rather than seeing it as a long-term plan, which it certainly can be. I also wanted to address the idea of behavioral challenges within the academic setting, as well as something that you highlighted in the school setting, as well as the type of care that's offered within the school setting. Because the shortage is there, and psychologists and counselors and social workers are seeing so many children, and primarily their focus is towards those individuals that fall under the law of 504 and IDEIA. Not to mention all of the other students who may be experiencing trauma, who just don't necessarily have a diagnosis and just are going through a very difficult time in their life. They may fall through the cracks easily. However, even the care that's provided in the school system is geared towards helping that student be able to be receptive to the educational system versus being able to talk about, I don't get fed at home, or I just was actually abused at my home. So those sorts of issues, it's generally a referral outside of the school setting because it's not geared towards academic achievement, even though it's very difficult to achieve when you are hungry or you've been abused. So I definitely do see that as a huge issue within the school setting with accessing mental health. And yes, with the behavioral problems with primarily, unfortunately, African American males, it is very often said, well, they may have ADHD or they may have an emotional disturbance, rather than saying or even considering, is it another issue, whether it's a family-based issue, whether it's truly autism, and or any other type of diagnosis that we would easily look to provide any other student. So it is very discerning to hear that especially African American males continue to be labeled as just being bad, which is the current label is that they're socially maladjusted.
We can take another question, comment.
I'm over here.
Okay. Say it loud now.
Okay.
All right.
What's that? Okay. For the Wilders, thank you for that astounding presentation, opening up your hearts. It was just off the hook. I have a question and a comment. Number one, I'll make the comment first. Planning for 2019, Kai, I would love to see you involved in that in the area of mental health services. I don't know whether you're here for the first presentation where Dr. James talked about having a comprehensive plan to eliminate healthcare disparities, and we've got 5 years to do that. The question is, how do we, as the African American community, protect ourselves from a lot of the mental health issues that come up as a result of stresses from society? I think that's the question. And then the last comment, you talk about African American males and behavior challenges. We have 3 children, 2 were males. I can tell you that they so-called had behavior problems and things in school. What I as a parent did, but I happen to be a pediatrician, so I understand exactly the kind of things you've been through. We got community folks. We went up to schools as a group when we were able to, and for folks that had the resources, we sat in those classrooms, watched the discrepancies just in terms of the way kids were treated. Our kids who were raising their hands all the time were the behavior problems, and the other kids were the smart kids raising their hands. And you had to go advocate at the school level, at the school board level, at the legislative level, but it takes a whole community and changing that environment in a community, and it's a lot of work. But anyway, the question is, how do we protect from those kind of stresses, all the kind of stresses we see in society? How do we protect ourselves? Because we're not going to undo racism immediately. We're not going to undo all the economic stresses immediately.
I'd like to comment on this because as a pediatrician, I see about 30 kids a day. And here in DC, our center is in Anacostia, right across from the Anacostia Metro. But this issue of labeling and tags, I see so many children, and largely African American males, who by the time they are in pre-K4, that's 3-year-olds, you guys, right? Pre-K4 are being sent to us. And a lot of times the teachers are writing notes to the parents that says, go to your pediatrician, this child needs medication.
Right.
Right? And it is for normal behaviors of any 3-year-old child.
Yes. Absolutely.
The thing that is really shocking about it, even one of my sons who's now 12, right, once got a discipline referral for raising his hand too many times to answer questions.
Yes.
And it was seen as a problem.
Yes.
Right? It's not a problem to me. So I think this is something we begin to teach at home, right, in protecting our children, just like you do as mothers and parents and families and communities and churches and our social gatherings. We do teach about the culture of racism. We teach about the biases that are within communities. We also have to teach about that in health. Right? That there are some people who may see behaviors that are normal behaviors as abnormal when they're coming from certain people. And our children have to be strong enough to, one, talk to their parents about it. Right? Do you know how many times children are taken out of a classroom and they never tell their parents? You don't even know that they spent half the day sitting in a hallway because of something that happened in the classroom. So being open to those discussions, I think, is one of the ways we start to bring down this stigma. And then the other thing is what I talked about in terms of the economic segregation in healthcare, right? We really do need community providers within our communities. One of the things I'm concerned about with the Affordable Care Act, and not the act itself, but in the creation of some of the ACOs, right, the accountable care organizations, is that we're moving more and more towards corporate medicine, where all of the providers will work for one of the 15 giant hospitals in the country. And I'm gonna tell you straight out, that's not a good idea for our communities. It's never been a good idea. It's not a good idea now. We need private providers. We need them on the streets. We need them in the schools. We need community groups working together. And I love the fact that you talked about getting the social workers, everybody working as a team. Well, the only way that happens is you actually have to know the school. You have to know the principal. You have to know the teachers, and they have to know the providers in that community.
Thank you, and I do agree. We need community teams, because where I am in Columbus, Ohio, at the Children's Hospital, and you have 7.5 minutes, sometimes 12, to address ADHD, all kinds of other social issues that impact health. You can't do it in an office setting. It is a community. It really has to happen in the village. Thank you.
So just one last question, and then we'll close up. Excuse
Okay. I was over here.
Oh, in here, okay.
Yes.
All right, we can't, all right. And then we'll, so, yes, ma'am.
No.
Oh, you're here first? Okay.
Yes. As a male social worker, I look around this room and I look at places where I go, and I see right now the opposite. In the prisons, I see obviously more African American males. Here, I see more African American females. When we're looking at providing services, the pipeline is rather dry of providers who look like the population that make up the businesses that we're profiting off of. So my question and my concern is, what do we do to get more counselors, more therapists, more social workers in the pipeline? If you look at the colleges around the country, you can find a women's studies program just about from coast to coast. What school, can anyone tell me, has a men's health or men's studies program in it? So we've got one out of 50 states, and thank you. And that's a problem, because when you look at African American boys, they grow up to be African American men. I was just riding over here today, and I was listening to the radio, and they were talking about the Affordable Care Act being able to provide services to men coming out of prison, which means that those numbers will swell. And I doubt very seriously if those corporations are going to want to treat those men. So we're going to need foot soldiers on the ground that can provide services to those men and to the boys that they spawn. So again, my concern and question is, what do we do to get that pipeline going? National Association of Social Workers, of which I'm a member, majority middle-aged white women. They're not, and on the reservations, white women. No disrespect to anyone that's out there doing the work, but for those that need the services, they're going to identify with someone with whom they can form a relationship. So where do we begin to put that in the pipeline so we can have that?
Right. Okay. Yep. Thank you.
In accordance with her question, the last question, as well as yours, I believe this is going to be deeply rooted in our communities. And going forward, I think it's absolutely imperative that we begin to empower the youth. The youth are our foot soldiers. Right now, being that racism is not going to end anytime soon, that we won't be able to necessarily squash that monster, or the economic difficulties that we are facing as a collective, and being that so many of our elders and the adults in our community are very much consumed with their personal businesses, having to operate in order to provide for what they already are accountable for. We have got to empower those who are not in the system, beyond what the healthcare system can cover, beyond what the government is responsible for. We must empower the individuals to take care of themselves and make that knowledge accessible. It's absolutely all it has to entail with the individual, whether it's therapy, social work as well. Those aspects of it very much have to do with the opportunity, the open space, the open environment for individuals to access understanding and knowledge regarding their circumstances and their experiences. And I think very much so for the black men, not only in prison, but in our society. It's imperative that someone that shares that understanding has the opportunity to share the experience and to go deeper in what they're experiencing. And those are the black men who are out there. And we've got to begin to empower them with the knowledge that is required for them to maintain a powerful state of being.
I'd like to add to that, actually. Mental health care, unfortunately, there's nothing been sexy about it over history. Most individuals that go into mental health feel that they either have some sort of mission or that they feel emotionally fit enough in order to not just handle their own issues and have the skills to be able to manage their own emotional fitness, but be able to give what we call sharing our ego to our clients in order to help them be able to manage the challenges in their world. So one of the questions posed was, how do we get more African American males out there into mental health? In part, helping our children become more emotionally fit. And I think this is a platform that should be global, actually. Investing in your emotional mental health. This is not an option, or it can be seen as an option. However, we see what has happened because it has been an option. The idea of becoming a mental health provider, we're not perfect. However, we do have to have the skills available in order to care for ourselves emotionally, and that is a priority for us in order to be able to provide the services that we provide to others. So the one way that I would suggest that African American males begin to move into mental health is making sure that we are instilling in them the importance of being emotionally fit.
Thank you. And I hope I'm not missing anyone. We'll take the last comment here. Thank you.
Hi, Fredette West with the Racial and Ethnic Health Disparities Coalition and African American Health Alliance. First of all, I just want to say thank you to Congresswoman Donna Christensen for the Braintrust and all that it does. According to the Department of Education, it reports that black students represent 18% of preschoolers, but 42% of students suspended once, and 48% of students suspended more than once. The question and the action is, how long will we tolerate it, and what are we willing to do about it? We do have power. We have to exercise that power. Going to vote and go home and that's it until the next election is a wasted vote. Do something with it. Our children are counting on us, and they should be able to.
Yes.
We cannot act as though we don't have the power to help fix some of this and wonder why we are continually treated the same way and expect to change. When are we really going to be sick and tired enough for being sick and tired enough to do something? We have the power. Let's do it. There needs to be.
Exactly.
And there must be a state of emergency as it relates to the elimination of racial and ethnic health disparities.
Right.
We are not black by mistake.
Right.
Let's do what we were brought here to do and do it well. Thank you.
Agree.
Well, I think that's a solid enough note for us to conclude this particular session this morning. Dr. Marshall, Dr. Wilder, Ms. Kia Queen Wilder, thank you so much for being a part of this morning.